This is going to be the PowerPoint presentation for Chapter 18 for EMT class, Neurologic Emergencies. We're going to be discussing several things. We're going to talk about the basic care and for neurologic emergencies, how to find them or how they present themselves. We'll talk about how decreased level, reasons the patient may have decreased level of consciousness, may have a seizure, a stroke, the things associated with those. Status epilepticus as it's related to seizure, TIA as it's related to strokes, headaches, the causes of those, and others, how they may be a symptom of other conditions. So let's get into it. Stroke is the fifth leading cause of death and the leading cause of adult disability in the United States. It's common in our geriatric or our elderly population. We see it often, and that's because as we know, as we get older, our systems begin to break down. Chronic conditions such as hardening of the arteries and high cholesterol leading to atherosclerosis. It could be family history and race are also contributing factors. But new treatments are coming out all the time in the for stroke, and that's why one of the things we'll do when we talk a little later about treatment is determine the timeline as to when it began to determine what level of facility we may be able to go to. We're going to talk also about seizures and altered mental status, and altered mental status is any mental status that is not normal. I know that may sound simple or silly, but we often think of altered mental status as someone who is unresponsive, but someone who is confused or in and out of consciousness also qualifies. Seizures can be from anything from a metabolic problem like blood sugar, could be something much more serious such as a brain tumor. They could have a genetic disposition for it, just have a seizure disorder. So we'll discuss those things. We'll talk about different causes for altered mental status, such as alcohol or drug intoxication, possible head injuries, low oxygen or hypoxia, someone who had a stroke, those metabolic disturbances, and how the treatments for each of these vary widely depending on what we find. So the anatomy and physiology of the nervous system. We have a central nervous system and a peripheral nervous system. We covered those in human body. The peripheral nervous system is our motor sensory nerves. However, our central nervous system is our brain and spinal cord. And we're going to be focusing on the brain today. The brain is like a computer. It's all electrical impulses in that tissue, and it controls breathing, speech, and every function in your body from hormone regulation to motor and sensory functions. It has three major parts. There's the cerebrum, the largest part, the cerebellum, and the brainstem. So here we see a diagram. We have to see our cerebrum here and see how much larger it is compared to the other portions of the brain. And then we have the smaller portion here, the cerebellum, and we have the brainstem, and you can see that's delineated from here down to here. And then we see a bone structure right here, but it's a side view. It would be a good thing for you to know that that bone structure is actually a hole in the base of the skull. It's the primary exit into and out of the skull, and it's where the spinal cord exits the skull and travels down your vertebrae or your vertebral column. And that hole is called the foramen magnum, and it'll come into play later when we talk about increased intracranial pressure, and when we get to trauma and start talking about head injuries, we'll definitely be discussing it then. So the brainstem controls basically our most basic functions. We have our breathing and our blood pressure, and you'll note that the one thing that's not in there as far as vital signs is concerned, we always think about heart rate, respiratory rate, blood pressure. Well, our respiratory rate and pattern comes from our brainstem. Our blood pressure comes from our brainstem, but our heart is independent on its own. It creates its own rate. Swallowing and pupil constriction are also controlled by our brainstem. And then our cerebellum is often known as the athlete's brain. It actually controls, it's where all our muscle and body coordination originate. The cerebrum, that largest part, is divided into two halves, or right and left hemispheres. The right side controls the left side of the body. The left side controls the right side of the body. And the front of the cerebrum controls your emotion and thought. That's your executive function, your problem-solving ability, problem-solving abilities, your creativity. All that comes from the front of the cerebrum. The middle is where your sensation and movement come from. It's hot, cold. We're moving around, our motor sensory input. And our sight centers are actually located in the very back of our brain. In most people, not all, but most, the speech center is located on the left side, in that left hemisphere, kind of in the middle. And that's important to know, because when we start talking about strokes and things, obviously it's not going to matter to us so much in the pre-hospital setting where the stroke is specifically happening, because we're going to be managing airways and supporting ventilation and supporting circulation in order to transport these people to the appropriate facility. However, if a patient is unable to speak or has difficulty understanding speech, and they have weakness on the right side of the body, then that would kind of tell us that it's more of a left side issue, as the speech centers are located on the left side, and we know that the left side controls the right side of the body. So messages are sent from the brain and to the brain from the body through 12 cranial nerves, and they run directly from the brain to different parts of the head. You don't have to know the 12 cranial nerves. You don't have to remember or memorize them by any means, but it would be good to remember that you'll always hear people talk about a vagal response when we try to get people's heart rates down, or maybe when someone went to the bathroom or something in the middle of the night, and when they were bearing down, their heart rate dropped. You'll hear people refer to a vagal response, and that's related to the 10th cranial nerve, or the vagus nerve. A vagal response related to the vagus nerve, because the vagus nerve is the primary nerve in the parasympathetic nervous system, and parasympathetic, we know, slows everything down. So just something to think about. The rest of the nerves join the spinal cord next to the brain through a large opening in the base, and there's that foramen magnum, that big hole that we talked about. It's primary entrance and exit. Okay, and at each vertebrae in the neck and all the way down the back, two nerves branch out, the spinal nerves, and these carry signals to and from the body. And then we have a diagram for that. We have we can see our cerebellum and our cerebrum up here in our brainstem. And as our spinal cord comes down to about here, we see our spinal nerves branching off, and then they branch off even farther to different portions of the body. So there's a lot of different disorders that can cause problems and issues with the brain. You might have anything from someone's having a level of consciousness that's not normal to, like we talked about just a second ago, their inability to speak, or their inability to speak, or they might lose voluntary muscle control or have twitching involuntary responses. And the brain's very sensitive to changes in oxygen levels and glucose and temperature. So all of these can affect how our brain actually functions. Any significant change can result in some type of neurologic deficit. So let's talk a little bit about headaches. There are a lot of people out there with headaches in the pre-hospital setting. A lot of them may be us. You've probably had a headache, and it probably wasn't anything terribly serious, but it is one of the most common complaints. And it can be a condition on its own, but in many cases, it is a symptom of another condition. So only a small percentage of headaches are really caused by anything serious. And most of the time you can pop a couple of ibuprofen or whatnot at home and they're fine. But obviously when someone calls 911 and we have to respond, we have to determine, is this a symptom or a condition on its own? There are different kinds. We have tension headaches, we have migraines, sinus headaches, or these three are pretty much the most common. So we'll talk about those a little bit. Tension headaches are actually caused by muscle contractions in the head and the neck. A lot of people attribute it to stress. We get we're bunched up, or people that will sit at a computer all day and they're leaning forward in an unnatural position can cause those muscles in our head and neck to knot or become bound up or stressed out. And that is usually described as a dull squeezing pain or just a generalized ache. Okay, and this is the primary one where we don't really seek medical attention. We do take a couple of ibuprofen and or aspirin or Tylenol or whatever your pain reliever of choice is. But then we have migraines. Migraines are much more serious. Patients diagnosed with migraines can actually take daily medications for them, and those medications typically affect the blood vessel dilation and constriction in the base of the brain, because that's thought to be the cause of migraines, those changes in blood vessel size there in the base of the brain. But the pain is usually described as very severe. It's pounding, it's throbbing, maybe even pulsating. Patients can often have nausea and vomiting. You might see visual changes, hallucinations, auras, and they can last. These headaches can last for several hours or even days. When you have patients that are on migraine medication out there that literally have a migraine more days during a month than they do not. Everybody's had a sinus infection at some point or another. If not, I certainly envy you. But sinus headaches are caused by that fluid accumulation in the sinus cavity. When we have infection or irritation in our sinuses, our body reacts by sending fluid there to transport white blood cells, and it thinks it's protecting or cushioning the area. And then we get that stuffy nose, and we get that sinus pressure. And that sinus pressure can cause us to have a headache. We've all had a sinus infection once again, I assume, and whenever you bend forward, that pain in the front increases significantly because of a fluid shift. So you can have nasal congestion, cough, fever. All of these can go along with the sinus headache. Pre-hospital emergency care is not required, but that doesn't mean that you're not going to respond to these calls. And then we have other serious conditions that include headaches, like hemorrhagic stroke, or bleeding out, or a brain tumor, even something as contagious and severe as meningitis. Talking about stroke a little more, stroke is called a CVA, a cerebrovascular accident. So if you see CVA written on a test, that's what we're talking about, stroke or a cerebrovascular accident. And that is an interruption of blood flow to an area within the brain. Typically, it can either be a clot or it can be a bleed, but it will result in a loss of brain function in a specific area where a clot has stopped blood flow from going, or where we have started hemorrhaging out or whatever, and so there's no longer blood flow past that point. So those two types of strokes are called ischemic and hemorrhagic. Ischemic strokes are going to be the clots. Hemorrhagics are going to be the bleed. Almost 90% of all ischemic strokes, those clots, almost 90% of all strokes are ischemic. They're clots. They're not bleeds. And they result from a vessel becoming blocked and not being able to, oxygen-rich blood not being able to pass that point to deliver oxygen, nutrient, sugar to a specific area of the brain. You'll see patients that have histories of atherosclerosis in the blood vessels having ischemic strokes, and that's atherosclerosis. Remember, is the narrowing of the vessels because of the buildup of plaque, and you have patients with high cholesterol and things like that that are definitely affected by this. And because we always think about heart disease being hardening of the arteries or the buildup of plaque, but atherosclerosis can happen in any vessel in the entire body. And here's a pretty good picture of an ischemic stroke. You can see we have blood flow just like normal throughout the brain, but once a clot lodges in, we have an area of the brain that no longer gets that circulation. And so this being on the right side of our patient would be affecting the left side of our patient's body. Hemorrhagic stroke, only 13% of hemorrhagic strokes are bleeds. These are often fatal. People at high risk are people that are experiencing extreme stress or exertion, and people who have a history of high blood pressure that's uncontrolled, or they're not compliant with their medications. Some patients have had high blood pressure their entire life. They don't go to doctors. They don't know they have high blood pressure. So these are the things that cause a vessel to rupture. And you can see right here, an aneurysm. I like to describe an aneurysm as basically everyone's seen a garden hose that got a weak spot in it and kind of ballooned out from the inside. And an aneurysm is basically the swelling or enlargement of wall of an artery that results in that defect, that balloon out. And then if that ruptures, because it's much thinner than the rest of the vessel, if it were to rupture, then they would bleed out into the surrounding space, and where blood was traveling past or whatever would now be bleeding out into the cranial space and not traveling through the vessels to deliver the nutrients and oxygen to the tissues that needed it. TIA, known as a mini stroke or a transient ischemic attack, can mimic a stroke identically. However, these stroke symptoms go away, could be in just minutes, could be in a few hours, could be up to 24 hours. But our big concern there is that within any time someone has a TIA for the first time, it's a really, really big red flag that a major event is coming, possibly within the next 90 days. About 1/3 of patients who have a TIA will eventually experience a full-blown stroke. And if we do have a stroke, TIA, once again, could mimic it or whatever. Some signs that go along with that are facial drooping to one side or the other. They may have sudden weakness or numbness in the face or on one side of the body. Could just be an arm or a leg. Could be the entire side of the body. That numbness is known as, or weakness is known as hemiparesis, whereas if they are unable to use that side of the body, it may be hemiparalysis. And lack of muscle coordination, which is known as ataxia or loss of balance, are also symptoms or signs and symptoms that are included with a stroke. They can have sudden vision loss in one eye. Remember, we have our sight center in the back of our brain, but we have a right and a left side. So if one side is being affected, we would lose vision on the opposite side. We may also have other vision changes like double or blurred vision, could have difficulty swallowing, a decreased level of consciousness, and speech disorders with if the speech centers are involved, like we mentioned earlier. Aphasia, slurred speech, sudden or severe headache in many cases in one specific place, especially with hemorrhagic stroke. They have a bleed, they'll be pointing to I started hurting right here in this one spot, and it hurts really, really, really bad. That's a big indicator, that sudden onset and point specific pain for a stroke. They may be confused, or they may be just something, maybe just slightly dizzy. They could experience weakness. They could appear to be someone who's intoxicated or on drugs and maybe combative, angry, restless, all the way down to completely unresponsive in a coma. So left hemisphere involvement, we talked about aphasia, which is that inability to speak or produce sound, and it can also include their ability to understand. You're speaking to them, but they don't understand what you're saying. They're not comprehending your words, or sometimes they're speaking incoherently, and they may act like they're saying a thing, but they're saying something else that doesn't really make sense. You can see a lot of frustration in these patients. Right hemispheres, usually they can understand language and they are able to speak, because once again, that speech center in most patients is located on the left side, but they may actually be oblivious to their problem. They may deny it. Yeah, my arm's a little weak or whatever, but they don't think about it. They blow it off. They don't go out and seek help, and that can lead to a very, very big negative outcome because they neglect their issue, because it doesn't have pain with it, and so they neglect it, and then they don't seek appropriate help in the appropriate time frame. If we have bleeding in the brain, high blood pressure may actually be the cause of the bleeding, or may be caused by the bleeding, and we'll explain that in just a second. So the high blood pressure being a cause of the bleeding, we already mentioned that over time, vessels can weaken if blood pressure is high and goes unchecked. And so with those weakened vessels, we form that aneurysm, that weak spot. And then if that aneurysm were to rupture, we have bleeding in our brain. However, if we have some kind of issue that's causing bleeding in our brain or on the outside of our brain or whatever, and is increasing is increasing our intracranial pressure, then our body is the pressure inside the skull. But remember, we just said that we only have basically one entrance and exit out. That's that foramen magnum. So it's not like the skull can expand and contract. So when pressure builds up inside, it puts pressure on the brain, and then you'll see the patient, their body reacts by sending it to their brain stem, telling their brain stem, turn up the pressure. We're not getting the oxygen and nutrients we need. More pressure leads to more bleeding, and so on and so forth. It's a cycle. Increasing blood pressure is an important sign. It can be associated with something called Cushing's triad that we'll see in head trauma. And significant drops in blood pressure can occur as our patient begins to decompensate, like in decompensated shock, when we see that pressure falling off there at the end. Things that can mimic a stroke, there's actually quite a few of them, but some of the big ones are hypoglycemia, low blood sugar, Patient might appear intoxicated. However, they can literally have weakness to one side of the body. They can have facial drooping, obviously slurred speech. A postictal state, which is a state of confusion after a seizure, can mimic a stroke. Or subdural and epidural bleeding. Subdural and epidural bleeding that's bleeding not inside the brain, but around the outside. And you can see we have our dura mater and pia mater, and we have our epidural hematoma right here, how it's between the brain and the skull, and it starts putting pressure back on the brain and reducing circulation to specific areas of the brain. Lots of seizure disorders out there. Seizure is basically short circuit in the electrical activity of the brain. The brain has all our nerve centers send electrical impulses from point A to point B, and it always goes from point A to point B, A to B, A to B, A to B. But when something happens and we start having a lot of A's go to a lot of other A's, or that impulse, then that impulse can be global and actually cause a seizure. And we have two different basic groups. We have generalized and partial seizures. Generalized seizures involving the whole body, partial seizures being a little more specific. And so our patient could have those bodily convulsions that we typically associate with seizures, or it could be something a lot more subtle. A generalized seizure is that abnormal electrical discharges from large areas of the brain, and these are the patients that can be unconscious and have that whole bodily muscle tension, twitching or whatnot, and that's going to be followed by a postictal state. The absent seizure, which can in many cases look like someone who just kind of daydreamed a little bit, doesn't involve any changes in motor activity, but your patient just kind of stares off into space a little bit and then doesn't seem to respond, and they come back in and we have a period of memory loss that goes with it. Focal onset aware seizures. Our patient doesn't have a change in their level of consciousness, but they may have some numbness or weakness in one side of the body or the other, or in both sides. And they can become dizzy. They can have some visual changes, color sensitivities, light sensitivities, blurred vision. They may actually have unusual smells and tastes. People who have focal onset aware seizures, will often know they're having a seizure because suddenly they smell a specific thing, and they always smell that. Whenever they smell that, it typically means the onset of a seizure, and these people will get themselves to safety. So focal onset impaired awareness seizure, that's your altered mental status. Okay, this one includes altered mental status. Once again, abnormal discharges, but usually from the temporal lobe of the brain. The temporal lobe is right there behind our temples on either side of our forehead. You might see isolated jerking or blinking, lip smacking, repetitive movements, and they may actually have something like uncontrollable fear, or they may have hallucinations. We obviously, when we deal with these patients, it would be easy for us to, associate them with psychiatric emergency, but we need to look at our patient's history and the medications they take in order to get a full picture. An aura, which is basically visual changes, or they may see a hazy outline of colors around different objects or whatever, can be seen in people that are predisposed to seizures. A lot of times they'll see an aura, they know that a seizure is coming, and in order to minimize injury, they'll go ahead and take steps. They could be driving down the road and say, "Oh, I'm suddenly seeing auras. I know I have a seizure coming on," and they may pull over, park the vehicle, and wait for a seizure to occur and pass. Or they could be at home and they would sit down on the couch, or depending on where they are, lie down on the floor so as not to fall because they knew it was coming. Generalized seizures are sudden loss of consciousness. We have the muscle tone that tenses bodily, and then we have the chaotic muscle movement. This is the one that everybody pictures when they imagine a seizure. The big thing that we want to worry about here is that a generalized seizure does include apnea, or the lack of breathing, which in most seizures is not an issue. a person with a seizure disorder has a seizure, it says here on your slide that it typically lasts less than 5 minutes, but 5 minutes is a long seizure. Typically, you're going to see seizure activity last, a long seizure is a minute, 2 on the outside. And if you think about it, there's no one that can't hold their breath for a minute without, a full recovery, or even 2 minutes. We might not like it if someone held us down and made us hold our breath for 2 minutes, but at the end of it, we would still be okay. So it wouldn't be a life-threatening situation. But these are followed by a postictal state, and that postictal state is going to be where they're regaining consciousness. You may walk up on a patient who is in a postictal state and they're not answering, they're not responding at all. And over the course of the next 5 to 10 minutes, they start staring at you, they start asking questions, they may repeat those questions over and over and over until they regain full consciousness. And that's a good thing. We want them to regain full consciousness. But if for some reason they do not and they have another seizure beforehand, then we would consider them status, and we'll talk about that in just a second. Absent seizures, we used to call big seizures or generalized seizures grand mal. Absent seizures used to be petite mal. That may last for just a few seconds, 5 or 10, but this is once again the patient that stares off into space. You see a lot of actually a lot of children are misdiagnosed with ADHD and things like that, and given medicine for the same, and then they continue to up their medication dosages because they're saying that the patient or the child is not paying attention in class when the child is actually having absent seizures and can't help it. Miss Math teacher Mary is giving out a math problem, and little Joey has an absent seizure, and he kind of blanks out for 5 to 10 seconds, and then the next thing you know is the math teacher's calling on him, and he has absolutely no idea what's going on, and the teacher's going to automatically assume that he just wasn't paying attention. And as that happens over and over and over again, we may lead to problems, parents being called, diagnoses being made. So the patient will fully recover after an absent seizure, but they won't remember that brief lapse in time that while they were out. In status, these are seizures that last more than 5 minutes and happen back to back. So we talked about having a generalized seizure, having a postictal state afterward, and then returning to consciousness. But if before they return to consciousness, they continue to have seizure after seizure with no break in between, or break returning to consciousness in between, these are the patients we consider status. So keep in mind, during that seizure, they're not breathing. That's not a big deal if the seizure lasts 1 to 2 minutes. However, if in that postictal state, they're not allowed enough time to reoxygenate or whatever before they go into another seizure, then we can definitely have an issue, and this can become a life-threatening emergency. So here's a little chart that tells you causes of seizures. Epileptic seizures are congenital in origin. We have structural issues like tumors or infections, and we have metabolic like hypoxia and low blood sugar, drug overdoses, withdrawal, and we also have febrile seizures, which is primarily in children, but febrile seizures, we always hear how people had people had a seizure because their fever was so high. It's not necessarily the actual temperature that causes a seizure, it's the sudden change in temperature that causes the seizure. You can also cool a child down too fast who has a high fever by putting them in a tub of cold water or rubbing them with alcohol or whatever, and by cooling them too quickly, you can cause a seizure as well. So this is a list of seizure medications that you'll see your population out there taking. Big ones, Keppra and Dilantin, Tegretol, Depakote, Topamax, and Klonopin. You'll see, and patients that are on these medications are familiar with their seizure disorder. These are the people that can feel the seizure coming on in most cases, that you may respond to them, and when they come out of that postictal state, they're like, I didn't take my seizure medication. I just want to take my seizure medication and go to bed. I don't want to be transported. Obviously, we encourage everyone to go to the hospital or whatever, but it can give you a certain level of comfort knowing that people with these disorders on these medications know a little bit more about their disorder than you do probably. So how is it important to recognize seizures? Okay, well, we need to know if this one that they're having today is different than their previous one. Have they been previously having absent seizures and with just kind of blanking out, but now they have muscle twitching involvement, even if it's something as simple as hand or arm twitching? And we can recognize complications, and hopefully we're able to identify other problems that are associated with that seizure. So we talked about that postictal state. After a seizure, everything relaxes, breathing becomes labored because they're trying to catch back up. You might have some hemiparesis, which is weakness on one side of the body or the other. But most commonly, you're going to just see they're just very lethargic, kind of out of it. They might be confused. If they don't improve and they don't have another seizure following, consider other underlying conditions. It could be low blood sugar. We always check a blood sugar on seizure patients, especially generalized seizure patients. When you're getting vital signs, blood sugar is a go-to. Break out the glucometer, because we're talking about a lot of muscle being used in an intense way for a period of time. And so it very easily, even if the patient doesn't have a history of diabetes, they can still be a candidate for hypoglycemia through all that energy burn. And seizures can often be mistaken for syncope, okay, or fainting. Someone kind of falls out and they twitch a little bit, and someone goes, oh, well, they fainted or whatever. Remember that we got to get a good medical history. And fainting, when someone faints and they wake up, they're alert. They might not remember fainting, but they know where they are and this, that, and the other. There's not a prolonged time period of them coming back around. Altered mental status, remember, is anything that is not normal. It doesn't have to be unconscious. It can be confused. It can be combative, and so forth. So any patient that's not thinking clearly or is incapable of being aroused, you can't wake them up even through verbal and painful stimuli. These are altered mental status. Okay. Causes of altered mental status could be literally almost anything from blood sugar and oxygen problems to drug and alcohol. Could be an unrecognized head injury that could have hit their head earlier today or even yesterday or last week. Could be something like a brain infection. They could be cold. Could be a homeless person out exposed to the elements, or someone who was out working in their yard and got too hot on a summer day without taking the appropriate breaks and hydrating appropriately. Or it could be, once again, brain tumors and overdoses. So we know how to size up a scene. We know scene size up contains 5 parts. We're going to make sure our scene is safe. We're going to make sure that we have the appropriate PPE on, the number of patients. We're going to make sure that we determine whether this is a medical call or a trauma call, or a NOI versus a MOI, nature of illness versus mechanism of injury. And we want to know if we need additional resources at this point. If we do have the possibility that we think there may be a stroke involved or some kind of neurologic issue, as EMTs, we might want to go ahead and call for ALS in this case. Go ahead and get them on the way so they arrive quickly. We know how to do a primary assessment. We know how to, if considered the possibility of needing C-spine control, controlling any hemorrhage, hey, are you okay? Checking the level of consciousness, how to establish our airway, make sure it's patent and maintainable, make sure we evaluate our rate, rhythm, and quality of breathing, and our rate, rhythm, and quality of circulation, along with what does the skin feel like, and doing another quick scan for any other major injury. So investigating our chief complaint, we do that through our history taking. For unresponsive patients, obviously we can't ask the patient, but hopefully there's a bystander around that saw the patient collapse, maybe witnessed the seizure itself, or maybe even someone in a family who actually knows the medical history of the patient and can tell you what medications there are. However, if there's no one around, try to determine the events leading up to the incident, or anything you can. You got to use your clues to try to find explanations, and obtain the sample history in any way possible. There's signs and symptoms, allergies, medications, past medical history, last oral intake, and events that we're leading up to. Secondary assessment, we know, includes our vital signs. Significant intracranial bleeds can lead to a great deal of pressure in the skull, and when it starts compressing the brain, it starts pushing on that brain stem. And we mentioned earlier how when the brain stem is involved, that's where our respiratory center is. So we may have erratic respirations. We may have our blood pressure going really, really, really high. You may always check pupils. You may see unequal pupils, and always make sure that anyone who has an altered mental status, we check a blood sugar. We're going to do also a stroke assessment. We have to do this obviously on a conscious patient. We wouldn't be able to do it on someone who is unresponsive, but there's several of them out there. Stroke scales typically look at the face, arm, speech, or whatever, and you're going to use the one that is used by whatever organization that you work with. Could be the BFAST, the Cincinnati, Los Angeles, the 3-item, and we definitely have to calculate Glasgow Coma Scale, or GCS, on every patient. And let's look at each one of those. This is the BFAST. You see a lot of your CPR classes, when they mention strokes and things like that, they teach just the FAST, which is the facial droop, the arm drift, slurred speech, and then time, how long ago did it first appear, and let's get them out of here really quickly. But the BFAST also adds in balance to make sure, has the patient lost their inability to stand or walk or hold themselves upright, and has there been any change in vision? So balance, eyes, and then fast, facial droop, arm drift, speech, and how long ago did it happen? We have the Cincinnati. That's a pretty basic one. That's a 3-part scale. Once again, it looks for facial droop, arm drift, and speech. The LA is going to be a little more in depth. Typically, if your organization is using the LA pre-hospital stroke screen, you're going to have this piece of paper that you fill out for each patient that you suspect of having a stroke. And it's got a little history involved there. Are they older than 45? Do they have any stroke history of seizures? Have the symptoms been did they onset less than 24 hours? Has the patient at any time been not wheelchair bound or bedridden? What's their blood sugar, and so on and so forth. And then once again, we get down to the smile, facial droop, grip strength, and arm strength. The 3-item, level of consciousness, arm drift, gaze. I'm not sure who uses this. It's pretty basic though. Most people go with that Cincinnati or LA. There's also one out there called the MEND assessment, and it is very, very, very detailed. You'll see that inside many facilities. But any patient that has any kind of altered mental status should get a GCS score calculated. And here's how we do it, okay? The maximum score is going to be 15. You have nobody gets a 0 no matter what. You get a 1 in each category. You get 1 through 4 in eye opening, 1 through 5 in verbal, and 1 through 6 in motor response. Eye opening, if they're just opening their eyes, looking around or whatever when you walk up, then obviously it would be a 4. That's for spontaneous. But if you walk up and you go, hi, Mr. Joe, and Mr. Joe opens his eyes and then closes them again, and then you go, Mr. Joe, and he opens his eyes and he closes them again, that's going to be a 3. In response to pain or pressure is going to be a 2, and then still none gets a 1. You got to evaluate how are they talking. Are they oriented? Are they a little confused? Are they using inappropriate words? Are they using sounds that you just can't even comprehend? Or once again, even if they're not speaking at all, they still get a 1. And motor response, if they obey all your commands, or they're a 6 if they respond to localized pressure, or localized, or they get a 5. If they withdraw from pain or pressure, that's going to be a 4. And if they're flexing or extending, that's going to be a 3 and a 2. But even someone who is unconscious or deceased still gets a 3 at a bare minimum. So our reassessment, we're going to focus on reassessing those ABCs just like with everyone else, getting follow-up vital signs, any interventions we've made, such as bagging a patient or whatnot. We're going to reevaluate, make sure we're still getting good compliance, making sure that our SpO2 is still within range, and we're going to reassess anyone with a neurologic emergency at least every 5 minutes. So how are we going to care for them in general? Okay, we don't have the ability to do a head CT out in the field, so we're going to call in what is known as a code stroke. If you suspect a stroke, you would call that into the receiving facility so they can be ready for you. In a lot of cases, you're going to roll directly in and go straight to CT. Many facilities won't even take them off your stretcher until a CT is done, and then they go back to an ER. Now, CT is going to determine if there's a bleed present or a clot, and they're going to want to know the last time that patient was being known to have no signs and symptoms. So that's a very important detail to acquire so you can provide it. Patients who have a seizure require evaluation and treatment. We strongly suggest you giving these patients oxygen. giving these patients oxygen because they have been in a state of generalized seizures where they weren't breathing for a while. If someone is actively having a seizure, I don't care what your grandma says, don't put a spoon in their mouth to keep them from swallowing their tongue. Don't put anything in their mouth. If you can help it. We want to make sure that we protect them and all those around them from harm. Don't allow them to hit anything. If their head is bouncing on a hard surface, you might want to roll up a piece of clothing, or if there's a pillow present or whatever, put it under their head. We never hold anyone down. We might try to provide spinal immobilization if there's some kind of head or neck trauma suspected. Providing oxygen is a big thing. We're going to try to clear their airway as quickly as possible using manual portable suction. For patients who have status epilepticus, remember that is seizure after seizure without returning to a conscious state, we're going to do everything we can to suction, provide positive pressure ventilations, bag them because they're not breathing on their own, and we're going to transport as quickly as possible. And if we can get to ALS faster than we can get to a hospital, we'll rendezvous with an ALS unit. If your patient complains of a headache, not a lot you can do other than evaluate to try to determine is this a symptom of something bigger, or if it's a headache with on its own. Sudden headache, remember, with fever, seizures, altered mental status, these things are much more serious. And ibuprofen, an aspirin, Tylenol, these things aren't going to cut it. These patients need to be transported quickly. Migraine, when we transport these patients, let's try to keep them in the dark. And I don't mean not let them know what's going on. Literally turn the lights down because they can be light sensitive. Don't use lights and sirens. Don't do it with the noise, anything to exacerbate the migraine. Always make sure that you remember it could be a symptom of something much more serious. And if they'll tolerate it, put them on some oxygen. That oxygen will replace the carbon dioxide, and that lowering of carbon dioxide can actually cause vasoconstriction in those vessels in the lower portion of the brain and can help relieve the symptoms of a migraine. For a stroke, a good stroke assessment is paramount. All our XABCs, bleeding, airway, breathing, circulation, we're going to cover that. We're going to maintain oxygen level of at least 94. If our patient is not hypoxic, we're going to withhold oxygen. There's no need to give oxygen if we're at 94 or better. And if you have a designated stroke center in your area, that's exactly where you're going to transport to, calling in that code stroke so they can have the teams ready and available. Seizure, if your patient, we've already kind of pretty much discussed this. If you arrive and your patient's in that postictal state, then obviously you're going to wait and see if they come out of it without having another seizure. Suggest they be transported. If they're actively having a seizure, we're going to continually assess our XABCs, protect that patient from harm, just like we did about, 3 slides ago. And if the patient refuses transport after having a seizure and coming back around, follow your local protocol, but make sure that the patient is aware of the possible negative outcomes with not being transported. And finally, care for altered mental status. Do everything we can to determine the cause. Is it hypoxia? Is it hypoglycemia? Do whatever we can to correct that cause if it's within our scope and we're able to. If we don't know if there was trauma involved, then we would obviously provide spinal motion restriction through manual C-spine, C-collars. Always for every patient, we provide airway support, making sure that the patient's airway is maintained open, and we ventilate our patient if needed. And then we would transport to the appropriate facility. And that's going to be it for neurology. For right now, I'll be posting another PowerPoint that has the review questions that you can go through at your own pace.